Hi, this is Ellen Grant, and I wanted to thank the organizer for the invitation to speak at this meeting. What I'm going to talk about for the next 20 minutes is the role of MRI in fetal therapies, and most of this will be actually the potential future role, but I wanted to point out all the things that are happening in MRI right now that may be of interest to this audience. Under disclosures, I'm on the Scientific Advisory Board of Aspect Imaging. So the role of MRI in fetal therapies is quite clear that qualitatively MRI plays a major role in diagnosis, but it also can be used for pre-surgical planning, quantitative phenotyping, and monitoring response to therapies. So in diagnosis, we've known for a long time now that the second line MRI provides a second line evaluation of abnormalities suspected or not adequately assessed by ultrasound. In addition, we'll screen for abnormalities, particularly neuroabnormalities, if there's a family risk or other abnormalities for a higher level assessment. There's many other areas too where MRI plays a significant clinical role. And again, this is in the qualitative visual assessment by trained pediatric and fetal radiologists. And here's an example here of a 28-weeker that was referred after an ultrasound for small cerebellar size, and the diagnosis on MRI becomes clear, which in this case is rhombocephalosynapsis. Now, the other thing that we found when doing a lot of this clinical imaging, we were trying to improve it and come up with strategies to improve it, and also ensure that while we're improving the imaging, we also stayed within the safety boundary zones. So what we started to do is take images of real fetuses inside of real mothers, the MR images, and create 3D models of them that we could then create 3D CAD models of and actually print objects that were based on these real fetuses and their structure. So here you have a printed fetus with a fetal head inside. This is a printed uterus, and that fits inside this model of the torso that was obtained from this 3D body. And these particular phantoms were designed for us for imaging, so we put materials in it to have the T1, T2 properties that we expect in fetal brain, amniotic fluid, and placenta, so we could develop sequences and test them out on these models. It allows us to push the envelope and not have to worry about bringing in mothers for every little single thing we want to treat or tweak or advance, and allows us to really test better the potential impact of our new strategies. We look kind of funny walking down the hall with this thing filled with fluid, and it is quite heavy, but it does really play a nice role in helping us to benchmark new approaches. So my question to you is this also something that would be useful for pre-surgical planning? You can imagine creating similar 3D CAD models of infants with specific genetic disorders or malformations that are candidates for in utero surgery, and have actual 3D models of that particular subject, either virtually if on a computer, in a computer system, or that you could print out in more sophisticated materials for training training purposes for fetal intervention. So I think it's something, these 3D models are becoming very sophisticated, and something that we should be paying attention to moving forward. In addition, we've been working really hard on quantitative phenotyping, particularly in the brain, because we want to go beyond the qualitative assessments, which don't have a very large dynamic range and can suffer from variability from reader to reader. So we want to provide quantitative metrics that are relevant to fetal brain development, and ideally relevant to what you all would like to do in the future in terms of interventions. Can we detect abnormalities that are actionable? And can we monitor the responses when you provide treatments? Now, some of the approaches we've been using, again, key on things we think are biologically relevant. So for example, gyrification, we know, is critical for functional organization. Up to date, the most common way to characterize or quantify gyrification is using a gyrification index, which characterizes the amount of folding, but not the pattern of folding. And it's the area of the inner cortex over this outer sort of shrink-wrapped surface. Now, function is determined not only by the amount of gyrification, but also the pattern of organization. So this particular gyrification index doesn't capture regional pattern variations. So we looked into, and actually this is Kehoe's work, the Sokal Pit hypothesis, which is the deepening of the first folds of the gyri that become the deepest local points of a sulcus. You can see some examples here. Their spatial distribution is related to brain function, and preserved over time, and importantly, under tight genetic control. So these locations of these sulcal pits emerge early in fetal life and are still there later in postnatal life, even into adulthood. Now, to use these sulcal pits to get evidence or to quantify gyral patterning, we key on the 3D position, area, depth of folding, and use a spectral matching technique. So looking at each of these sulcal pits, we look at the depth, the position in 3D space, the geometric relationships to other areas of sulcal basins that are around these sulcal pits, and calculate the area also of these basins. And then again, using these spectral matching techniques, we can compute a similarity index, which allows us to compare sulcal pattern and quantify the similarity of gyral folding between different brains, either between an individual and template of normal or between different individuals. And to show you how this works in clinical practice, here's an example of two fetuses that were scanned on the clinical service at 25 weeks gestational age. The similarity index to our atlas of normal was more than 80%, or slightly, close to 80% here in the top one, but less than 78% here on the bottom fetus. So the top one was much more similar to normal than the bottom. These are the surfaces that were reconstructed from these fetuses. These are currently not available for qualitative assessments during clinical reads, but you can see that the cingulate sulcus is atypical and the fetus on the bottom, and the central sulcus here has not started to appear. This fetus was born with normal gyral topology and had a normal outcome, whereas this fetus developed diffuse polymicrogyria, and you can see these cysts as well too. So this was actually a case of CMV, where we were screening in utero to see if there was any abnormalities that were evident. And these became quite clear postnatally, but the gyrification was very abnormal right from the beginning. So a qualitative read that was false negative, but picked up in our quantitative analysis of the similarity index to normal. Looking over a number of fetuses that we did this on, there's again a small number, it was only 6 at this point in time. You can see the triangles are the similarity index, and the circles are the normals. And you can see that there's a fairly good separation from the abnormal cases. These are cases, again, scanned as fetuses where we have postnatal confirmation of abnormalities, that we can detect these abnormalities with the gyral similarity index. Gyrification, however, showed no separation. And what gyrification index seems to do is really track the timing of the gyral folds, but doesn't really tell you whether the gyral folds are abnormal or not. And actually, when you look at the statistics, one of the biggest driving feature that distinguished the normals from the abnormal was the 3D position, or where the gyral folding occurred in both the left and the right hemisphere. So importantly, we need to track not just gyrification, but where the gyri start to form and how, and their topological relationships. And the concept is to develop these curves, these normal distributions of what are the typical similarity indices that you have in any individual fetus, and then identify those that are, say, less than 5% of the typical distribution, and which is what we did in this particular study. So we're working on characterizing this normal distribution better so we can provide this on the front line as a quantitative metric of abnormal gyral folding, and key people to look a little closer or to follow these fetuses more closely for potential cerebral abnormalities. Now, it's not just those gross cerebral malformations that can be detected with this technique. Kehoe is also with Cindy and Caitlin looked at the congenital heart disease population, fetal population, to see if there's any abnormal gyral topology in the developing fetal brains of fetuses with congenital heart disease. In this case, we saw no differences in the gyrification index again, with the surface area, brain volume, and cortical volume all being the same. However, the sulcal topology was different in the left hemisphere in the earliest depleting sulci, and the sulcal location and relationships drove these differences again. So again, position is really, really important in terms of picking up differences. Similar left hemisphere altered folding has been identified in children with single ventricle congenital heart disease. And in the older patients, this is correlated with executive function and damaging de novo variants. So the fact that we're starting to see emergence of these differences in sulci that appear early suggests that there may be more of a genetic influence and actually a deprivation, oxygen deprivation influence on brain development. but this is under further investigation to see if we can further prove that these abnormalities are more related to abnormal gene expression versus decrease in trophic supply of oxygen and other nutrients and trophic factors. Now, it's not just the surface area that's relevant in terms of picking up variations in regional gene expression. We have to also look at the cerebral mantle, and this is work Lana has been working on with Ali at Children's Hospital as well, looking at the thickness of the cortical plate and in the subplate region and characterizing regional growth of these areas. She has shown that these are sexually dimorphic and there's spatial temporal differences in regional volumes of the cortical plate and subplate with gestational age. And she's just working on a paper now that will soon be submitted that ratios of these thicknesses do correlate in some regions with gene expression. So we think we have some tools that can help us dig into abnormal gene expression and figure out and pick up some very early signatures of regional abnormal gene expression, which may be very important for future therapies and also for understanding genetic influences on early brain development. Now, to do this more routinely, we're trying to get a pipeline together that takes the standard HASTE images to create these volumes, and we use code that has been provided to us from Maria Dupre now. And also now with AI approaches, we can automatically outline the inner cortical plate surface so that we can create these surfaces, identify the gyral pits, automatically label the sulci, look at the sulcal typology, and get sulcal regions or gyral regions from these images. So we have a pipeline in the works that is pretty much ready for deployment to multiple centers to enable further collaboration on studies of these fetuses in larger populations across multiple centers. And just to show you how in the midst of doing this, we found some really important features that I think are useful even for clinical service. This is a 20-week fetus that where there were cerebellar abnormalities, no other cerebral abnormality was detected despite 2 reads when there was this study was acquired. But when we ran the reconstructions just as a test to see whether we might be able to put these 3D volumes into the standard clinical workflow, we could see that there clearly are these heterotopias in the ventricular along the pendimal surface that were really hard to confirm on the acquired fetal images because you're never quite sure if you're getting the same region. So you can't co-localize because the fetuses move over time. So it's really hard to coordinate whether this is exactly the same location as we see here and here, whereas we can do that with a coherent volume that can be created retrospectively. Currently, this takes a few hours, and we're working on, again, as I said, automated pipelines. So this, these images can also be provided at the bedside for, or at the monitor and at the workstations for immediate interpretation qualitatively as well as quantitatively. Other approaches that we're working on are to give you more quantitative information is powered by deep learning. And this is a deep learning algorithm that Kehoe and his team put together to estimate fetal gestational age. Gestational age is on the bottom and predicted age by their algorithm is on the y-axis. You can see there's a really good correlation. And I think the difference here is actually less than 2 days, only 1.8 day difference off of what is true age. Using that, they've looked at males and females, showing that we get a significant maturation of males relative to females. So female brains seem to mature a little bit slower than male brains in this data. And looking at other malformations, germinal matrix and abnormalities, germinal matrix hemorrhage, polymicrogyria, and microcephaly, we can see that in each of these disorders, the brain is shifted to younger gestational ages than would be predicted. So we think that if we can get this into the front line again, it's another quantitative metric that will enrich and supplement the head circumference that is currently used to estimate gestational age and to key the clinicians when there may be an abnormality. Of course, when you're studying the brain and fetuses, you have to pay attention to the placenta, as that's the organ where nutrients are transported across. This is just a video showing oxygen transporting right here across the maternal placenta to the fetus. Oxygen causes the signals to increase in signal intensity. So you'll see here the fetal side will get bright as the mother breathes oxygen and the increased oxygen supply to the placenta, which then is tracked to the fetus. We can pick that up here. This is resting state, the fetal placenta, or the placenta at maximal signal, and then the residue here after we've taken off the oxygen. Looking at the time it takes for the oxygen to reach peak in the placenta, we compared that with brain volumes in twins, as well as liver volumes and birth weights. And again, we chose twins in this particular experiment to fix all the other parameters that can affect that oxygen transport, such as maternal position, genetics, maternal blood pressure, and so on. And what we showed is that when there was a longer time for the oxygen to get to the placenta, so a longer time to plateau, the brain volumes were smaller, the liver volumes are smaller, and birth weights were less. And Kehoe, taking a look at these twins, we take the two different fetuses and look at the placentas that correspond to those. When we get the twins that have the, say, better functioning placenta, and the twins with the slower time to peak, when Kehoe looks at the gyrotopology, we pick up significant differences in the gyrotopology. And that is something we're further exploring, because we think this is an example of identical maternal environment and genetics, different placental function, with environmental influences on brain development. So we're gathering cord blood to see if we can find evidence for altered epigenome and altered gene expression. Now, fetal motion is something that is very important as well, too, and it's used clinically, especially in, say, for example, Chiari malformations, and to assess leg movement. In our center, we do not do fetal interventions, but in sites that do, it's also used to, there are different types of approaches to quantify fetal motion pre and post surgical intervention. So the question is, can we quantify fetal motion and not just do the qualitative metrics that are typically used? With using a collaboration with Martino, or with the MIT, Elfar Edelsteinson and his team, we've used machine learning approaches that key on different joints of the fetus. So these are the elbows, the shoulders, the elbow, the wrist, the knee here, and the ankle. And we can track fetal motion over time. And this is a surface rendering of that same fetus, showing how the fetal movements can be tracked with these key points, allowing us to quantify fetal motion over time. So we can track motion, we can quantify motion, and we're hoping to use this as well for some of our strategies to improve image quality, to predict motion, so we can come up with more sophisticated acquisition schemes. Now, what I've showed here are actually a clinical example of a typical fetus here on the left and a Chiari-2 malformation on the right. In the graphs in the inset up here is the ankle at the knee. And you can see in the typical fetus, there's a lot of variation in the ankles, in the angle of the angle at the knee. Whereas the fetus that has the lower, the spinal meningocele has a knee angle that is quite large, so not very flex, but open with not very much motion. So we can see clear differences, and actually can quantify those differences over time in observations of these fetuses over about, this is about 2 minutes. This is the accuracy of our quantification so far. We're within 5 millimeters of most of the joints, but we still want to improve it and get more accuracy, particularly with the head, torso. And we need to integrate into our scheme tracking the field ankle movement, which we currently are not capable of doing. So that's on the horizon of where we're going next. So in monitoring response to therapies, if we can use many of these methods, and I've showed you multiple examples, and there are many others that other groups are working on that are available to quantify structure and function of not only the fetal brain, but of different body parts and of the placenta. And really what we need to do is to collaborate to develop tools to capture the biology that's relevant to the intervention that you all are thinking about. Because we need to target in on the key points of the key things you are looking for to diagnose a specific abnormality that you want to treat, and to see if we can pick up immediate responses, or at least longitudinal responses over time while in utero, responses to those therapies, so we aren't always complicated by waiting for 18 months to get, say, follow-ups at 18 months of age. So the role of MRI in field therapies is really emerging to quantify structure in most body organs and to create subject-specific models to practice interventions. In addition, we can characterize motion in not only the bodies I showed you, but heart, body, and uterus. We're working on ways to characterize uterine contractions. And there are a lot of strategies out there to characterize placental function. So question that I then have for you guys, what information do you need? We would love to work with you to try to create the technology to do it. Thank you very much. And I'd like to thank again all my team for their work and that contributed to what I've shown you in this talk. Thank you.